Hello, everyone. I thought I would start this. I'm Donna Cutting and I am the moderator for this session. So the title of this presentation is the impact of the COVID-19 pandemic on rural nursing. And I'll introduce Dr. Laurie Johansen.
Hi, everyone. I am Laurie Johansen and I come from Minnesota. I had my friend and colleague sitting back there. Now she just stepped out for a minute. She gave me a ride here. So I was going to introduce my driver from Minnesota. But I am a professor of nursing at SMSU in Minnesota. I've always had an interest in rural nursing research. I've lived in a rural community my entire life. I've practiced nursing since 1981. So you really got to date yourself. And so I've always practiced nursing either in practice or academics since then. And so rural nursing is very important to me. And that's kind of what spurred my interest in this topic. I'd really like to know my audience to know a little bit who I'm speaking to. Who would say they live in a rural area? So my definition of rural was the US Census Bureau 2,500 and under. Who would fit that criteria? So a few. Who has worked in a rural hospital, like a critical access hospital? You know, mine has a 10. My census right now in the facility near where I live is a 1.7 census per day. So we have 0.7 people out there. We have 0.7 of a person. I found a lot of the participants in my study fit that. And I have a growing concern, like all of us, about the nursing shortage and specifically in rural areas and what that's going to do to the people that I care about in rural areas. So that's what sparked this topic. So I'm going to figure out how to change slides here. And it's not advancing. By hitting enter, hitting forward. It was. I practiced. And also hello to the people out in Zoom world. If you have questions along the way, please feel free to jump in or wait till the end. Be glad to take questions. While he does that, I'll breeze through the presentation objectives when we get to the next slide. I think you can see that in the information in the program. Little background. I can do it. So we do have a significant workforce shortage, and I have some data on that. US Census Bureau shows that the need for employment of RNs is projected to grow 6% from 21 to 31. However, IRBOC et al. Talks about the total supply of RNs decreased by more than 100,000 in 1 year, which is a far greater drop than ever observed in the past 4 decades. And they felt like that was due to early retirements, pandemic burnout and frustration, COVID, related staffing shortages, and other disruptions throughout our healthcare delivery organizations. 2022 National Nursing Workforce Survey showed 28% of their respondents plan to retire in the next 5 years. The 2022 annual survey for AACN showed enrollment in baccalaureate programs decreasing. And lastly, more specific to rural, RNs in rural, the Rural Health Information Hub reports data from HRSA in 2021 showing the differences in distributions in RNs from rural versus urban. And that was fairly alarming to me. There's always been a difference in distribution, but it seems faster. The findings revealed 64.5 RNs per 10,000 rural residents was 64.5 compared to 93.9 RNs per 10,000 urban residents. So a lot less availability of RNs out there in rural areas, vast difference. So it's imperative for us to be able to support future nursing workforce. I feel like especially in rural areas, little is known about the impact of COVID on the rural nurses. And so hopefully my study will shed some light on that. I did complete my study in 21, 22, and so I'm in the process of analyzing data. And so I hope this is beneficial for you. I'm going to breeze through how I did my study, because I think you're more interested in the data, but I did do a phenomenological study, and it did look at the distresses experienced by nurses practicing in rural communities. Actually, they were practicing nurses living in rural communities, not necessarily practicing in rural communities. And so the ultimate goal was to be able to inform nursing practices in order to provide support for future outbreaks. That's what I wrote in my IRB. In the end, it was like, we just got to keep learning about rural nursing. And so that was the purpose. This was my approach. I did do purposeful sampling with snowballing. I did semi-structured interviews using phone and Zoom and analyzed my data. And so my findings showed the essence of the phenomenon was that there's multifaceted physical and psychological strains while being a nurse in a rural community during the COVID pandemic. And if I look at specific components that came out, I found staffing, practice of nursing, being a rural nurse, occupational strain, social burdens, and supports as key components within that essence. And so I'll talk about each of those components a little bit here and give you a picture of their experiences, their life experiences. So I'll first talk about the component about staffing. And before I talk about staffing, I want you to know that all the participants shared concerns about staffing, not having enough staff, the number of hours that they were needed to work, the number of patients that they needed to care for. They also shared concerns about future nursing workforce. And that's probably not news to any nurse that was working in the pandemic. However, as long as there were so many hands that went up for rural, you got to think about how rural is staffed as I talk about these topics. So a lot of them have facilities where there's 2 RNs on the shift. So there's not a lot of flexibility in that. So a lot of urban nurses can't fathom that. And there's 2 RNs in the whole facility. And sometimes by evenings and nights, they're the only 2 people in the whole facility. And also the number of nurses on staff, there might be only 12 in the whole facility on staff. And so you don't have a lot of depth there. And so you got to keep that in mind as we think about this. So not enough staff came out as a consistent topic. They talked about that routine staffing, how there's only typically 2 on, and with that staffing structure, they just said, we just didn't have the manpower for it. You ended up doing double and triple duty. They went on to talk about the hours worked. The amount of hours worked were highlighted with feelings of obligations to work because there was no one else to do so. Participants shared feelings of concerns about who would take care of their people from their communities if they didn't work. There were many stories about working many 12-hour shifts in a row, working 18-hour days, but they truly felt obligated that they just had to show up for work. And so another quote is, I think I worked, it would be like 9 shifts a pay period. And is that what I was doing? That's what I was doing all the time. And that's those 12-hour ones, 108 to 120 hours a pay period all the time. They went on to talk about the number of patients that they had and the drastic changes in the number of patients they were serving. So keep in mind, like in my facility, I just shared, our average census is 1.7. And she said, I can't remember, I can remember one night in particular having 3 COVID patients who were not doing well and then getting the 4th. And I can remember crying at the end of the night because I didn't even see the 4th person. I was so thankful that that person was stable enough to do things on their own, and that my charge nurse kind of took over, because I don't think I'd have ever made it into the room. If that was really demeaning, because whoever wants to not see their patients they're assigned to. Time with patients was talked about. So beyond the actual number, their experiences about the time they could spend with patients. The one said, when we get all dressed up and all that, the patients want to talk, they want to chat. So we're the people in there. We get chatted with. Last night, one of my patients asked if I could sit with her and watch a movie with her for 10 minutes. And I had to tell her no. I wouldn't have time. And I would have, if I would have had time, I would have, just because she's been by herself for about 2 weeks now. And she isn't going to go home soon. This was really interesting. The nurses experienced feeling expendable because there were not enough nurses, but there were more nurses than there were workers in other departments like lab and housekeeping. So one stated, I definitely felt at one point like we were the expendable group. We were doing it all. Housekeeping didn't have to go into the rooms. The doctors weren't going into the rooms or respiratory therapy. The nurses did it all. We even did the labs. And so that was a ticket to burnout. They felt the healthcare facilities were trying hardest to prevent exposure to the department's most minimally staffed due to COVID-19, which wasn't necessarily nursing departments. Additionally, nurses were sharing on one hand that they were working excessive amount of hours, like I just shared previously, while others who were primarily staffing departments that were not being used to full capacity due to COVID, like surgical departments, they weren't getting the hours they were used to. And so one stated, we're going into a healthcare crisis, yet they're firing, laying off, and nurses are quitting. So it was really unique times. Feelings about our future nursing workforce also surfaced. Participants talked about staff leaving healthcare and going to factory jobs or taking classes to transition to different roles in the healthcare industry. One stated, it ate away at my soul, and there were so many times that I questioned, what in the heck am I doing in healthcare? Which I know lots of nurses, anybody in healthcare has thought, what are we doing in this crazy field? Another stated, I'm just thinking of rural nursing. When I think about that, if I think of her healthcare facility and the surrounding communities, the number of available nursing jobs, and we don't have the workforce to fill that. And it scares me to think about what we're going to do. On a positive note, some reported that they wouldn't do anything different. They are still glad they are nursing. They really did get to help somebody and wouldn't trade that for anything. So here's one quote. We've had a couple of nurses return who had quit during COVID because after they get away from it, you realize how much you miss it, how it filled your heart, which has been wonderful to see because they were super employees. Another one said, if anything, it maybe has made me feel more committed to remaining here in this area and wanting to stay in long-term care, especially, even though the future of long-term care is incredibly scary right now with our aging population and our decreasing workforces. The silver lining through all of this has probably been that the clarity now that I know I'm in the right seat. I know this is where I need to be. It's unfortunate that it took an event like that to provide that additional clarity. So there were some joys in hearing that. So I'm gonna stop talking about nursing and go to the next concept, which was practice of nursing. There was a lot of talk about practice of nursing. As participants talked about their actual practice of nursing, there were many feelings shared about nursing being a high-risk profession. Someone stated, I didn't know that I would put my life in limit risks to go to work as a nurse. There's no way to project that out into the world. They also shared how overwhelming it was having lots of changes to the practice of nursing occurring at once. Guidelines and procedures changed on a daily basis or more. Mixed messages occurred, changes got changed, and learning had to occur fast. They had to figure out what rules to bend. Someone stated, the uncertainty of the changing rules constantly was, everybody, we're learning as we go. So I'm going to tell you this right now. It could change in 15 minutes. Please just know I'm doing the best I can with the information I have right now. So, and you got to remember again, the number of staff that have to sort all this out in a rural area. And then they talked a lot about PPE challenges, the many challenges, supplies, usage, and how that impacted nursing practice. I'll touch on that more in a future concept, but so they talked about the need to use their full scope of practice. Experiences were shared about their roles as rural nurses, and more specifically, their roles as nurse generalists. And, you know, they do it all. And now they were doing way more things than they've ever done before. One shared, we've actually been getting a lot of patients from the cities. They can't go back to a skilled facility. They can't go back to assisted living because they have COVID, or they are just weak from it and they need that swing bed experience. And that's what we've been getting a lot of, that swing bed experience. I worked last night and we had 3 COVID and we had calls for 8 new referrals trying to get swing beds. They need a little more time in the hospital and a little bit of therapy. So we've been turning down referrals quite a bit. So they were not used to turning people away, and they were turning away what they considered to be vast numbers. Quality of care within their practice of nursing work had concerns. As they were trying to keep patients safe, they were feeling that they were losing sight of quality of care in the world of business. They had no time to pause and figure out a better way. So they were just doing more and more with less. An example was that they were not always able to transfer the patients to appropriate levels of care with the current COVID staffing models. One quote was, "You're getting critical patients coming in and getting them shipped out to more skilled facilities. Right now, everybody's having trouble with open beds, but we have a stroke patient right now we can't get a bed for. They've been accepted by 2 or 3 different hospitals, but they just don't have a bed for her. We do have a BiPAP, we have ventilators, all that, but we only have 1 or 2. So if we get a big influx, we're going to be overwhelmed very fast." So they were caring for people that they usually had shipped to higher level care. They witnessed human suffering, as many did in COVID. But we got to keep thinking about this was in a rural context. They witnessed so many deaths, feeling that there were so many unnecessary deaths, deaths of people they knew, and many deaths without family members present. Nurses became substitute family members. One person said, "We had people that were dying without family members around them. We were the ones that were with people when they were dying, and that's very, very impactful." Another stated, "I don't want to do that again, and I don't think I'll let it. I might get fired for breaking a rule, and I'd be okay with that because that was heart-wrenching. If my husband was in the hospital, I'm going to be by his side, and so I hope we don't do that again." And another said, and this really speaks to that rural setting, "Of course, these people, I knew them. I was a kid who'd grown up with these people who were the adults in my universe. Buried 12 of them." So, okay. Stepping onto the next component, I'm going to talk a little bit about their feelings about being a rural nurse, which was described by all the nurses through their experiences. One thing that came out consistently was a general respect and appreciation for nursing that was found by all the participants. And I've seen this in other research. So just a lot of trust. I'll let you glance through those quotes. It just felt a lot of trust in those from those community members. Everybody knows everybody, and that's a pretty consistent thing that comes out of rural. They share experiences about that it's hard to take care of patients when you know them, and I'll let you read those quotes again as well, and how people appreciate you taking care of them because they know you. And so those are things that people that we're dealing with COVID that aren't in rural areas probably couldn't relate to. Being a nurse, they talked about identifying themselves not only as a nurse, but an individual in the community. And one of the challenges of being a rural nurse surfaced when they interplayed. It's stressful because there's an expectation that you have to be following the right guidelines all the time since you are a nurse. But also you're a human too. And you have a husband and kids that want to get normalized too. And it's kind of a fine line. So they couldn't walk away from nursing. Everybody knew they're a nurse. And so they found it meaningful to help people that they knew, and they had some boundary challenges that we've always found in rural. So I'm not going to dwell on that a lot since I got my first sign. So I'm going to go on to the next concept was occupational strain. Varying experiences about occupational strain, but consistent to be both emotionally and physically tasking. One thing that was consistently found to be emotionally tasking was the feeling of fear. They shared being scared of not knowing how to do the right thing, not knowing the best thing to do, not knowing how to integrate COVID into their lives, fear of catching COVID, fear of keeping coworkers safe, fear of spreading COVID to others, fear of bringing COVID home. One participant stated that they would just cry because they didn't want to go home in case they would give it to their family. And there was also the fear of bringing COVID back to work and to their patients. A lot of guilt. Guilt about possibly quitting their job, needing to be out to quarantine for COVID and the impacts that has on their fellow workers and patients, and losing empathy. Someone stated, patients almost make you feel like it's your fault that they're sick. I'm finding that hard to deal with, whether it's the patients or you see people on the street. They felt blame put on them. And they felt guilty about that. There was guilt about visitor shutdowns and those impacts. One participant said, I'm trying to meet visitors at the door of the healthcare facility, and I'm trying to enforce a policy. You hate to think of being denied access to your grandfather because he's got COVID, and sometimes the nurses are the front line and they are the only people there. They are the COVID police. They are the ones that let people in or not. So another participant shared concerns about visitor shutdowns, seeing people deteriorate from sadness, loneliness, helplessness, and boredom. Seeing someone on your Zoom call is not the same as having them right next to you. And one nurse shared that she had so much guilt about her family staying away from her because she was a nurse in COVID. I didn't see my mom for probably over a year because of this, and people just don't get that. Stress, lots of levels of stress. And I listed some items here. I think nurses are compassionate people and you want to make people feel better, and you can't always do that. And you can't do that, you take it home with you and you feel like you've failed. And there was stress about family being at home and the moms, and how do you handle all these kids that are home and not in school, and you're at work and they feel like they're obligated to be at work. And so a lot of that. And then it got down to the stress of COVID shots. And it seems like it's a long time ago. No, it wasn't that long ago. And the desire to have that COVID shot. One said, I tell you, I prayed so hard just for those vaccines to come. I don't know about you, but can we just make everyone get vaccinated? Can we please? And so very stressful. And beyond the emotional trial was the physical things. And I'm not going to go into a lot of that, but that physical, the workload, the PPE, it was just very physically tasking. So interesting stuff really came out of a concept of social burdens. Social burdens involve the nurse's role in the community and being the one that says no and having to meet expectations to do the right thing. So they felt like they were the COVID police at home, in their healthcare facilities, and in the community. They felt they had to meet expectations for all nurses to do the right thing. One quote said, I had to tell a couple of my friends that I didn't feel comfortable having them come to my house or having their kids running around my house because they're not vaccinated and they don't take any precautions. They shared how they experienced the public views of nurses. One said, the people I interact with, 2/3 of them would take a step back when they saw me because they were afraid I was contagious. And they shared community actions. Even though they were trying to support you, then they would go and do the opposite of what was recommended, which was really hard. So people have their own perspectives and their own ideas. One said it does not do any good to try to educate people about something they're hearing about just on Facebook and social media or from the wrong sources and that kind of thing, because they're still people, number one, and they don't believe COVID is real. They don't believe in it whatsoever. And it just doesn't do any good after this amount of time to have discussions with them. And one said, you have to stay silent, because I think sometimes it's more political than anything. And I'm not going to get into a political argument with someone, which I think I did in the beginning. I heavily did. I totally did. I was like head in all the time. And now I'm just like, no, there was just too much resistance. They talked about the need for support and where they could get support. They needed support. They couldn't talk about their feelings. One said, I didn't know that I would put my life in limit risk to go to work. There's just no way to project that in the world because you can't even talk about it, right? You can't, not being able to discuss that kind of thing. There's nowhere to say it out loud. But they found a lot of support in family, colleagues, and administrative report. One quote that was kind of special. There were many businesses and individuals that would get everybody Subways for the day or pizza. They would send special gift baskets. We had some families that donated amazing gift baskets. When the cloth mask craze hit, we had tons of ladies in the community who were just busy making cloth masks. It's fun to randomly see a cloth mask in a drawer now. It makes you think of how crazy it was at that time. So one thing you do in my type of research is once you get your data, then you immerse yourself in the literature to see what you find there that matches what you're finding in your data. And so these are some of the things that I found, that It is stressful to accommodate new protocols in the midst of increased volumes and intensity of work, which they experience. There is anxiety that occurs during outbreaks of new infectious diseases. And that's probably not all unique to rural, but it does match what we found. And there is fear of contracting illnesses and unknowingly spreading it to others. There is moral distress that goes along with this. There can be low morale and traumatic experiences and it drives people to leave the profession. But one study by Gomez was interesting. Despite fears and negative emotions, there is a desire to be in nursing that was strengthened in nursing students. So always some positives. Looking at the literature to see how we could use that to create workforce support. Some of the things that come out is you want to be able to ensure reasonable workloads. I'm not sure we could, if we did the pandemic all over again, I don't know that no, there's no solution. There's no answers in the literature that says, how would you do that? Provide practical support, consult with nurses regarding their needs, and provide unambiguous communications. And that peer support groups can be very invaluable. There's some stress management techniques that you can follow. But just there were many physical and psychological stresses experienced by the nurses. In the context of workforce shortages, the potential future implications are concerning, and we need to learn from the past, which is a key to our future. And I really felt like I'm going to go back and I went to the IRB and I wanted to use this to learn how we could better be prepared for another pandemic. But we need to learn what I really took away. One of the keys was when that nurse lives nursing day and night in that community. People know they're a nurse. They live nursing, those social burdens, what they expect out of nurses. We got to understand that, and our administrators need to understand that, and the people that are working with those nurses. So